Hi, good morning. Thank you very much, Matthew, for that wonderful invitation. I have to say it's a little daunting being at Stanford. This is certainly one of the pinnacles that I recognize from an academic world. And thank you for the opportunity of giving rounds this morning. Really, the learning objectives are to allow me to provide some discourse and personal opinion about the world and the pathway of the academic surgeon. I have no disclosures. And just as a land acknowledgement, Stanford sits on the ancestral lands of the Muekwa Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. Consistent with our values of community and inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. So the term Quo Vadis really means where are you marching, where are you going? And it was something that Peter said to Christ after the resurrection, as Christ was walking, and Christ said, I'm returning to be re-crucified. And I think that inspired Peter to continue his ministry, which ultimately resulted in him being crucified as a result. It's a little serious first thing on a Tuesday morning. It's also the name of a movie about Nero and Rome that won Peter Ustinov a Golden Globe in 1951. And this is a talk that I've been thinking about for some time, and it started in 2017. At the University of Toronto in spring, we have what's called the Galley Day. And the Galley Day is a celebration of all the academic productivity at the university and the Department of Surgery. And every year we invite an individual to come and give a lecture. And in 2017, Alan Kirk was invited. Alan is the chair of the Department of Surgery at Duke. He is a renowned transplant surgeon and really a remarkable individual. And he gave the Gordon Murray Lecture that year on co-stimulation blockade for organ transplantation. But he started his talk and said, I can't believe I'm at the University of Toronto. This is one of the last bastions of academic surgery. Do you realize that you are an endangered breed? And I was completely taken back by his thoughts, because here's somebody who I think is at the top of the academic pyramid and actually saying to us, academic surgeons are an endangered species. And he quoted this article here from the Nature editorial at the time saying more surgeons must start doing basic science research. And that started me thinking that maybe things weren't quite as good as I expected, because I was on this train track. Everything that I was doing was focusing on academic productivity. I was stimulating people to be academically productive. And I really thought that everything was aligned in that way. But when I started to dig, I found a number of concerning thoughts. Academic surgeons' interest is decreasing in a linear fashion. Grants awarded by the NIH to the top 25 academic medical centers have been decreasing, and found the proportion of funding to surgical departments has dropped from 3% to 2.3% over an 8-year period. Within individual medical faculties, the proportion of money going to surgical departments is also decreasing. When you look at the number of abstracts submitted to the Academic Surgical Congress, proportion related to basic science has fallen by almost a quarter. And it's consistent with earlier studies that show fewer surgeon scientists apply to NIH for grants, and those who do tend to be less successful than their medical colleagues. And even in the United Kingdom, they found that surgery has had a decrease of 20% in the total numbers of clinical academics from the turn of the millennium. And now in this day and age, there's half the number of lectures in academic surgery than there was in 2000. In 2000, a survey amongst academic surgeons demonstrated that many believed in the value of basic scientific research, even if they were finding that clinical and administrative duties hindered their success. But in 2016, another survey suggested that only half felt that basic research was a priority in their departments, and a third said it was realistic to expect surgeons to succeed in basic research. Most of them said that they had neither the time nor the motivation for research, and in any case lacked adequate departmental funding and support. To me, this was very concerning. This prompted a response by the Canadian Association of Chairs of Surgical Research to develop best practices for enhancing surgical research. And they described that surgical research in Canada is experiencing a decline in funding and an increase in challenges affecting research productivity of academic surgeons, with pressures to be clinically active with unpredictable surgical schedules, growing administrative demands, and increasing complexity of patient populations. And if you think that this isn't current, this is going to be presented at the Plastic Surgery Research Council meeting in June of this year. And this demonstrates that in the world of plastic and reconstructive surgery, there's a significant decline of trainees doing MD, PhD surgeon scientist training programs. And so this gave me some opportunity to pause and sort of think about where is the future of academic surgery. And really, over the next a little while, I'd like to go on a discourse or share with you a bit of an odyssey about my pathway for academic surgery, what I think some of the challenges are, and perhaps where the opportunities are for the future. It would be remiss if I didn't touch a little bit about the history of surgery. And like many of you, when you have a medical student in the operating room and you're doing a complicated operation, there's not much for them to maybe engage with, but one thing that you can ask them is anatomy. And you can also ask them what their perception of surgery is. And it's a very common question for me to say to a first-year medical student, what are the biggest advances in surgery over the last 200 years? And we go on this sort of journey of talking about the history of surgery. We have a very rich history. It goes back to trephination, that goes back to 5000 BC and the Incas and the Celt skulls. And there was even evidence of reconstruction that was done with small bony rondelles. Hippocrates has talked about in his treatise the application of surgical techniques for certain injuries. This is from a hieroglyphics of an Egyptian pyramid dating back to 3000 BC, showing surgical instruments in the hieroglyphics. And any of you who have an interest in this, this is a wonderful book by Sir Harold Ellis on the history of surgery. In 1600 BC, the Edwin Smith Papyrus was discovered, demonstrating details about 48 cases of injuries, fractures, wounds, and dislocations. And I love this description here. It says, instructions for dislocated vertebra. Thou should bind it with fresh meat the first day, loose its bandages, and apply grease to his head as far as his neck. Thou should treat it afterwards with honey every day, and his relief is sitting until he recovers. This is a paper from 1505 demonstrating the treatment for open skull fractures. And if you encounter a cranial bone fracture presented with either a wide defect or with multiple smashed bones, so that when the bony parts are removed, a wide hole will occur, you are obliged to repair this defect by the following procedure. Find a youngster of a goat and slaughter it. A goat is not available, and you can use a dog. So Schroeder has impacted my world of plastic and reconstructive surgery as he described the first forehead flap for nasal reconstruction. Nasal amputation was a very popular punishment for those being caught as an adulterer. And the fact that he actually had a patient population to develop a technique on suggests that there was great demand for this. And then there's the myth of St. Cosmas and Damien, who, according to legend, took a healthy leg from a deceased man and did the first allotransplantation in the 14th century. But surgery really didn't take hold until the time of Henry VIII. And a man by the name of Thomas Vickery in Kent was a physician who happened to treat Henry VIII as he came through with a chronic varicose leg ulcer. And he did such a good job that he was appointed surgeon to the king. And in 1530, he was appointed as master of the Company of Barbers. This is him here. And then in 1540, he incorporated the Company of Barbers and the Guild of Surgeons into the Company of Barber Surgeons and stated, surgeons should no longer act as barbers, and barbers should restrict their surgery to dental extractions. Then he organized the surgeons into professional bodies to distinguish them from quacks, itinerant tooth drawers, and charlatans. And he actually created a training system with a 7-year apprenticeship and a qualifying exam. And one of the bonuses of being in the training system was the opportunity of dissecting cadavers. And to this day, this association of barbers and surgeons continues. Any of you who see a barbershop will see that red and white pole outside of it symbolizing blood and bandages. But really, when did the first academic surgeons start? And you can argue that anybody with curiosity who happens to do surgery could be considered to be an academic surgeon. In some of the research I did, I realized that being an academic surgeon was potentially harmful to life and limb. Michael Servetus, who was a surgeon in the 1500s, was the first to describe the pulmonary circulation. And he wrote that blood having been mixed with air and lungs passes back into the heart. Unfortunately, John Calvin described this as an execrable blasphemy. And as a result, Dr. Servetus was burned at the stake atop a pyre of his own books in Geneva. Ambrose Paré was a French surgeon who stated that to perform surgery is to eliminate that which is superfluous, restore that which has been dislocated, and separate that which has been united, and join which has been divided, and repair the defects of nature. But he's most well known for saying, Je le pensais, Dieu le guérit. I bandaged him, and God healed him. And you could argue that perhaps he was one of the early academic surgeons in that he wrote a book on the treatise of surgery. He developed a method of managing gunshot wounds. And he was the very first to suggest ligatures for hemorrhage as opposed to hot irons. And his writings and instructions are known to be the beginning of modern forensic pathology. John Hunter was felt to be the father of modern scientific surgery as he applied the scientific principles to surgical areas. He had interest in looking at human teeth, doing the first transplantation. He was interested in bone growth and remodeling, inflammation, treatment of gunshot wounds, venereal diseases, and he was also the very first to do the first artificial insemination in 1790 on a linen draper's wife. And one of the bonuses about being a surgeon back then was that whatever you removed from a human, you could actually keep. And he had a collection of 14,000 anatomic specimens, which now reside in the Hunterian Museums in Glasgow and in London. And any of you who have a chance to go should have a look at what's left over from his collection. So Ashley Paston Cooper was a well-known physician and surgeon who came to renown because of his interest in vascular surgery, especially the cerebral circulation. He was the first to develop surgery for aneurysms, and he has a number of anatomic structures, such as Cooper's fascia, Cooper's ligaments in the breast, a number of diseases, and was very prolific in terms of his treatises and books that he created. There were also surgeon advocates at the time, and Semmelweis was probably one of the very first surgeon advocates. He was professor of obstetrics from Hungary, but worked in Vienna. And he recognized that when doctors and medical students looked after women who'd just given birth, there was a maternal mortality of 18%. And he recognized that there was a carriage of cadaver particles from the morgue to the delivery room. Yet when the midwives looked after these same individuals, the mortality was much less. And when he instituted chlorine hand washes, you can see that there's a dramatic decrease in the mortality for post-puerperal fever. I think Lister also deserves credit as being the father of modern surgery because of his work as being the pioneer of antiseptic surgery. He was a scientist, a pathologist, and a surgeon, and really without him today, what we do, I think, would be considered to be very unsafe. But really, when you look at it, modern surgery, I think, really took its roots at Johns Hopkins, and the great four of Welch, Halsted, Osler, and Kelly, who were the various chairs of pathology, surgery, medicine, and gynecology at the time, revolutionized the way that we train people. And Halsted was a remarkable individual. He really was integral in forming the first surgical residency training program at Johns Hopkins. And I love this quote that he said, "The only weapon with which the unconscious patient can immediately retaliate upon the incompetent surgeon is hemorrhage." And any of you who have an interest in this should read this book by Gerald Imber. Gerald Imber is a plastic surgeon in New York. And he talks about Halsted and really sort of opens some light on his character. He was very frivolous. He liked to wear special shirts that he had made in Paris. And he would only send his shirts back to Paris for laundry. He's well known for his addictions of morphine and cocaine, but he also was the first to develop rubber gloves. And the story goes that the reason he developed rubber gloves was that his operating nurse with whom he was having an affair was having chapped hands from washing her hands. And so to protect her hands, he developed rubber gloves. But really, we owe Halsted a huge debt of gratitude. And subsequently, if any of you who are interested, his life has been characterized in a popular television show. So what is an academic surgeon? Well, Osler described anybody who did academic medicine or surgery as being a triple threat: a clinician, an educator, and a researcher. And Robert Sutton describes academic surgery as a perfect balance between the practical and cerebral. You must be interested in the intellectual challenges of the broad discipline of surgery and not just want to be a cog in the wheel. Academic surgery and medical education was very much influenced by the Flexner Report. It came by Abraham Flexner in 1910. And this was really designed to provide a higher level of oversight in medical training. And he had a number of recommendations, including reducing the number of medical schools, increasing the prerequisites to enter medical training, train physicians in a scientific manner, and engage in research, give medical schools control of the clinical instruction in hospitals, and strengthen the state regulation of medical licensure. He was quoted as saying, "An education in medicine involves both learning and learning how. The student cannot effectively know unless he knows how." Unfortunately, some of the downsides to his report was the closing of several medical schools that focused very much on training Black African Americans. And so it's a little of a double-edged sword, but certainly provided the foundation for the medical education system that we use today. And Ernest Leroy Boyer was an American educator, and in 1990 wrote Scholarship Reconsidered, Priorities of the Professoriate, which challenged the then current views of faculty priorities and devised 4 kinds of scholarship: discovery, integration, application, and teaching. And this really formed the basis for the ACGME guidelines for scholarly work in residency training programs. So what exactly is an academic surgeon? And this is an article that I'll share with you. It comes from the Michael DeBakey Department of Surgery at Baylor. And what they did was they looked at 7 academic surgeons who they considered to be the top in their field. And they interviewed them and they looked at their CVs. And what they found was that these group of 7, the average age was around 63. They'd been in practice for 30 years. They were all in leadership positions. And on average, they had 288 scientific publications. They had 80 book chapters. They had almost 500 scientific presentations on average to their name, total lifetime funding of almost 9 million. And they trained anywhere from 33 to 800 people as part of their career. And I'm going to come back to this a little bit later. And these are some of the details, but essentially what they felt the 7 attributes of the archetypal academic surgeon were: to identify complex clinical problems ignored or thought unsolvable by others, becoming an expert, innovate, advance treatment, observe outcomes, disseminate knowledge and expertise, ask important questions, and then subsequently train the next generation of surgeons and scientists. Very, very laudable qualities for the academic surgeon. And as we know, surgery has basically risen to the greatest heights of academic, and there are 9 surgeons who've not won the Nobel Prize. And I like this quote: academic surgery is not an oxymoron. So why did I choose to become an academic surgeon? So I was fortunate enough to go to the University of Toronto and did my surgical internship. And then I did my surgical research training with Cho Pang. And this is a very young Peter Nelligan standing next to me and Cho. And this was part of my training in plastic and reconstructive surgery. And I was one of the very, very early pioneers in the surgeon scientist training program. and this was a gentleman that influenced me tremendously. W.K. Lindsay was the professor and chair of the Division of Plastic Surgery at the University of Toronto for 23 years. He practiced for almost half a century as a former American Association plastic surgery president. He was a farmer and a statesman, and he was really one of the pioneers of advocating surgical research. He actually trained under Bill Bigelow, who was a cardiac surgeon who developed the cardioplegia, cold cardioplegia techniques to do safe cardiac surgery. And WK used to run the Chicken Club. And this was a group of trainees that would spend time in the lab looking at flexor tendon healing using a chicken model. And so WK was a great influence on me. I graduated from my training program in 1990. I did fellowships with Joe Gruss at Sunnybrook, with Rick Phillips and Walter Sullivan in Detroit, and then with Bruce Cannell in Santa Ana, California. And then I looked for a job. And I came back and interviewed with this gentleman, Bernie Langer. And Bernie Langer was a very well-known hepatobiliary surgeon and was the chair of the Department of Surgery for 10 years. And I met with him as part of the interview. And he looked at me and he had this terrible tendency of never blinking, which is very disconcerting when you're in a situation like I was in. And he looked at me very seriously and said, "Chris, Sunnybrook Hospital is making a very big mistake in hiring you." And the reason was that he felt that my research training was not adequate enough to set up a lab and to be successful in academic surgery. And what he wanted me to do was to go away for another 2 years and continue to do postdoctoral research before I took on a job. Fortunately, the people at Sunnybrook decided not to listen to him, and I was able to get a job there in 93. And then in 1999, I moved to the Hospital of Sick Children. And then in 2003, I think my career changed significantly in that I took on leadership roles, first as the chief of the Division of Plastic Surgery, and then in 2011, as Matthew has mentioned, as the chair for the Division of Plastic Reconstructive Aesthetic Surgery in Toronto. And why did I choose to become an academic surgeon? I was desperate to be one of these people. And they're fairly well known: Paul Manson, Peter Nelligan, Susan McKinnon, Ian Taylor, Ian Jackson, Jim Rutke, who is the chair of the Division of Neurosurgery and chair of Department of Surgery at U of T, Joe Gruss, Nancy McKee, and W.K. Lindsay. And I was so stimulated and inspired by these people that I wanted to join that club. And I've had, I think, really a very blessed career. I think my productivity has been modest, but I've been able to develop a very remarkable clinical profile. I have transitioned from basic science to a number of areas, including surgical simulation and the application of robotics. And I've been really, really fortunate to influence a number of trainees at all levels. And I think the secret to my success has been collaboration and mentorship and being able to have good support from people like Cho Pang throughout my early career. And this has really been something that I've truly valued. But when I look a little bit more carefully, I can see that as my academic productivity rose in my first few years and my administrative load was fairly low, as soon as those intersected, my administrative load has become quite high. And I wouldn't say that I'm not productive, but my academic productivity isn't as good as I would like it to be. And Robert Sutton has said this. He said, "Academic surgeons need to be versatile with excellent written and verbal communication skills, a reservoir full of perseverance, patient skill, zeal, and resilience to cope with the hurdles of publishing, securing research funding, and being able to move smoothly between clinical research and productivity. You must maintain your productivity in original research while also excelling in clinical work. And the key to doing what research project you do is whom you pick it with. And aim high, be in an international center with a thriving biomedical and clinical research community. And certainly when I started, the pros and cons of academic surgery are fairly obvious. You can be an all-rounder in your specialty. You're in a position where you can bridge clinical science and basic science research and clinical work. It's a perfect platform to influence peers, and there's substantial personal and public reward. But it does come at a cost. And the cost really relates to the amount of time, work-life balance, and limited scope for financially rewarding work. And so when I started my career in 1993, this was sort of the road ahead, and you can see where it's going, but I must say, for me, it wasn't the easiest road to travel. And much of my time, I felt like this. You know, I was working, pushing against the stream. I was trying to be a really good clinical surgeon. I was trying to establish my reputation in the world of craniofacial surgery. And I was also trying to be productive in the lab. And this quote by John Gardner says, "A society whose maturing consists of simply acquiring more firmly established ways of doing things is headed for the graveyard. Even if it learns to do these things with greater and greater skill, an ever-renewing society, what matures is a system or framework within which continuous innovation, renewal, and rebirth can occur." And this has resonated with me for the last several years, because I think continuing to do what we're doing and continuing to expect people to be productive without adapting to what's going on in this world, I think is doomed for failure. Sharon Stein wrote a lovely position paper back in 2013, basically looking at some of the challenges in scholarship and academic surgery, and highlights a number of areas that we're currently facing. Financial viability in the departments of surgery. Now, in Canada, it's a very different system than what you have here, but I think we do share some common concerns. The economic crisis has affected our endowments significantly, and we rely highly on our endowments to provide support for research. There have been budget cuts, and in Canada, we run on a budget system. Once we've used the budget up, then there's nothing left. Healthcare reform has certainly affected the landscape in the United States, and there's no question that healthcare is rising in terms of its cost. And for us, government funding has been flatlined for the last few years, and there's an expectation that we will continue to do more with less. And a study from a few years ago demonstrated that when you look at leaders in terms of chairs, time allocation, 60% is administration, 12% research, 16% teaching, and 11% patient care. And many of these leaders felt that they were no longer to be considered as a triple threat. The financial viability of research is also a problem. If you look over a period of time, there's been a significant decline in terms of the numbers of R01 grant applications. There's been funding shortfalls. Even if you get funding, in my world, it may not be enough to allow you to complete your research. And so we're very dependent on philanthropy. And also the time and research needed to develop an R01 funding has changed. In 1980, the average age of an R01 lead investigator was 37. By 2010, it's gone up to 45 years of age. So there's definitely challenges in terms of doing research. Other challenges in academic surgery relate to faculty retention and promotion. And many of the issues that are cited, including longer work hours, lack of job prestige, and not being appreciated. And frustration levels and burnout levels, I would say, are an all-time high. Work-life balance is a concern to not being able to provide the patient care that you'd like to be able to do. There's a lack of commitment to improve patient care systems. There are fewer clinical role models. And in my institution, there's been a huge trickle-down effect of administrative burden, and that shutbacks have resulted in higher levels of administrative burden on people like myself. And I have to say that using Epic as an electronic medical record has also increased the number of hours a week that I spend in front of a computer. And a 2001 study of faculty at the University of Colorado found that 42% of the respondents were seriously considering leaving academic medicine in the next 5 years. And this is a problem because once you start to move people around, it incurs significant costs. And it's also sad to find out that almost half of entry-level faculty leave their initial appointment, 21% move to another academic appointment, but 79% leave academia entirely. So there's something wrong with the system. I can also tell you that recruitment has also been a challenge. We've been trying to recruit a number of American surgeons to come to the University of Toronto, and the Canadian dollar just is not a big enough draw. And I just came across this in the news that Theodore Grancherov, who's a colleague of mine, he works at St. Mike's, will be joining Stanford, and this is a great win for you. Theodore is a remarkable surgeon. He's a general surgeon, but he's the one who developed the black box concept in the operating room to analyze how surgeries proceed. So I'm sure it took a lot to get Theodore here. We'll miss him at the University of Toronto, but it just illustrates an example of some of the challenges in terms of recruitment. I would say that faculty promotion is something that is also a challenge, and the faculty assessment scores tend to be biased in my world to the senior surgeons. Teaching as a pathway to promotion is not quite so defined as that of basic science, and the metrics that we apply to teaching, I would say, are unfair. The H index as an opportunity of providing academic merit is something that's very interesting. And the Skeptical Scalpel, which is a blog by a surgeon, has talked about this as perhaps an artificial metric to be applied. And the role of continuing professional activity as a platform for promotion is very subjective. And unfortunately, in my world, there's a significant level of apathy, like, why should I bother getting promoted? It doesn't really mean very much. And I think this has relevance because we need to look at the people that we're working with, the generational issues. And we know that if you look at the traditionalists, the baby boomers, Generation X and the millennials make up the majority of people that are in our world. And I think it's important, especially as a leader, to understand a little bit about the characteristics of these people. The traditionalists, of which there's not many left, are very dependable, straightforward, tactful, and loyal. As a baby boomer, I'm very encouraged to hear that I'm optimistic, competitive, tend to be a workaholic, that's definitely true, and team-oriented. But I do need to pay attention to the Generation X's and the millennials, and then finally, the Generation Zs, which are coming down the pipeline and will make their impact. And I like this quote, "Life is what happens to you when you're busy making other plans," by John Lennon. And just as we're carrying on in the world, in March 2020, everybody felt like the floor dropped out. And this tiny little thing overshadowed the planet. And as a result, images like this, that 5 years ago, you'd have no idea what they mean, have now become relevant. So we have to adapt to the world situation and what's going on around us. And I like these quotes. "There's no education like adversity," by Benjamin Disraeli. Mary Tyler Moore said, "You can't be brave if you've only had wonderful things happen to you." And any of you who haven't seen Ted Lasso should definitely watch it. Taking on a challenge is a lot like riding a horse, isn't it? If you're comfortable while you're doing it, you're probably doing it wrong. And so we at the University of Toronto, despite what was being going on in the world, we did receive some very good news last year, and that we've now been voted the #3 global university for surgery. And this is a great honor. And it's interesting because when you look at the metrics for this, these are the standard metrics that we would use. And this is taken from my annual address that I gave last year. These include things like peer-reviewed funding, peer-reviewed papers, growth and expansion, teaching effectiveness scores, promotions, innovations, patents, and discoveries. And these are truly remarkable metrics to be able to apply to a department of surgery. And I demonstrated last year that our division is doing very well. We had over 200 peer-reviewed papers in a year. That's probably what Michael Longacre's productivity is like in a week. But for us, I thought that was pretty good. And we've also done very well in advancement in philanthropy and supporting our surgeon scientist trainees. And so, the metrics of what, or the overview of how our department was doing was actually quite good. But I want to go back to this slide here, because these are 7 individuals who I would consider to be unrealistic role models. And when you look at their productivity over that 30-year period, I think it's very, very difficult to be able to sustain this type of productivity. It comes at a great price. And as somebody who would be starting a career in academic surgery and seeing this paper, my fear is that they would be daunted as a result of looking at this and think there's no way they could ever succeed. And so what I've decided to do is to change those metrics of success and apply a different series of values. And I'd like to talk to you a little bit about those today. The workplace harassment and bullying is something that I think is something we need to pay attention to. And this came to my mind a couple of years ago because at the University of Toronto, they did an assessment of the medical student experience, and they found that 42% of medical students have experienced public humiliation or gender discrimination, 16% have experienced unwanted sexual advances, and 26% have listened to racially or ethnically offensive remarks. And this is not just in medical students, but it's in our world of surgery as well. And this paper from a couple of years ago from Yale suggests that surgical bullying is the perfect crime that leaves no visible marks, but effectively destroys one's ego, identity, and resilience. And that almost 47% of surgeons both trainees and practicing surgeons have reported being a victim of bullying, and 68% report witnessing bullying. Bullying can be described as the systematic abuse of power and is defined as an aggressive behavior or intentional harm doing by peers that is carried out repeatedly and involves an imbalance of power, either actual or perceived, between the victim and the bully. And 6% of people who are bullied have active suicidal ideation in surgery. And where this resonates for me the most is that up until January 2021, if a medical student came and talked to me about a career in my division, I would say, you know what? The nice thing about the culture of plastic surgery is it's a very, very benevolent, benign culture. We're really a group of really nice people, and it's a safe space. In January 2021, a trainee came to me and said that she had been experiencing significant bullying and harassment at the hands of an individual staff surgeon in my division who'd actually been recognized by the Royal College as one of the top educators. And this individual had targeted this learner. And she came to me, and it was a fairly significant situation. And what she explained was that as a result of the rotation, she had gone into therapy and that she actually overcome this. But then she had this moment where she realized that if she allowed other people to experience what she'd experienced, that she couldn't live with herself, so she came forward. This led to generating a pathway of being able to report this type of thing. But it led me to poll the last 15 years of our trainees, and I sent them an email and asked them a simple question. During your training in our program, have you ever been subject to harassment, bullying, or intimidation? Response rate was 75%, and to my dismay, 30% said yes. And the bullying sources included staff, co-residents, nurses, and then specifically the anesthetists and the emergency department staff. And so this has led us to come up with a new mandate that suggests that there's no excuse for bullying, harassment, or intimidation of learners in the workplace. Learners need to know that their place of education is safe and that there's an opportunity for these concerns to be heard and dealt with. And the idea of creating a culture of speaking up is something that I think is really, really important moving forward. Wellness is something that also resonates. This is Todd Mainprize. Todd Mainprize was a neurosurgeon at Sunnybrook Health Sciences Center who I knew peripherally, but he's one of these people that you read about because he gets these prizes and awards and accolades. And unfortunately, Todd took his own life 2 years ago, left a family with 3 children and a loving wife. And I thought to myself, if something like that can happen to somebody like him, this was very, very concerning. And when you look at physician wellness, there's lots and lots that's been written about this in all different specialties. And the burnout crisis has also been discussed as well. And there are 6 causes of burnout: unsustainable workload, perceived lack of control, insufficient rewards for effort, lack of a supportive community, lack of fairness, and mismatched values and skills. And I hate to say it, but these are not dissimilar to the world that we work in as academic surgeons. And in my world of plastic surgery, if we think we're immune to it, this study suggested that almost a third of plastic surgeons would consider themselves burned out. And I would say a year ago, I was definitely one of those individuals. Even including the residents, this is also an issue. So one of the things that we have started in the division that I think needs to be addressed is resident wellness. And Joanna Rosell is one of my latest recruits. She's a global surgeon. She graduated from Harvard, has been working, was my fellow, and then we've just recruited her. And Joanna is the resident wellness director for the division. And she did a survey of our residents, and she found that of the 28 residents, 17 responded. 30% had admitted to having significant depressive episodes throughout their training. And she discovered that wellness is an integral component of resident life, and it's linked to being professionally successful. But the barriers to wellness include control over time and having personal time and escape from work. And there's a synergy between feeling well and being bullied. There are concerns with expressing these struggles to program leadership, and it's definitely an issue. So Joanna came up with an ingenious system to help wellness. And based on the Harry Potter house system, she created 3 houses named after Mangelo, McKee, and Zucker, who are well-known alumni. And so as a result of this, resident wellness is an important part of our curriculum. This was a puppy bonding session in a puppy rescue house that we had in December, followed by Korean barbecue in the freezing cold. And so this is something that I think is really starting to resonate with our trainees. EDI is on the agenda for pretty much every institution now, and we're blessed to have Laura Snell, who's a co-director. She's a microsurgeon who works at Sunnybrook and does breast reconstruction, and has taken over as the co-director for EDI in the Department of Surgery. But I've been able to capture her talents within my division, and she came up with a position paper that talks about the application of EDI It's unfathomable that we delay any longer the dismantling of these injustices. Together, we can build a surgical department where diversity, equity, and inclusion shape its culture, inform its academic mission, and inspire its members. We must come together in solidarity. And so last year, we've developed an EDI curriculum for the Division of Plastic Surgery with the goals of enhancing awareness and improving opportunities for EDI application in pretty much every aspect of what we do. And it really came to fruition. I'm very proud to say that I'm the only old white male in this committee, by the way. But it really came to my attention during a recent selection process for our residency training program. And Nancy Baxter, who's a general surgeon, tweeted that it's unbelievable in 2018 anyone thinks mentioning a candidate's appearance in a reference letter is appropriate. As Margaret Stager had said that research studies show that male applicants are described in reference letters as strong, capable, as intelligent, and women applicants are described as nice, attractive, and friendly. And I realized that there's a significant bias in the way that we review people and also the way that we assess our applications. And this leads to the issue of meritocracy, which is something that has really struck me of late. Meritocracy relates to the holding of power by people selected on the basis of their ability and involves the idea of rewarding those who exercise their talents and succeed. Credentialism is a belief in or a reliance on academic or other formal qualifications as the best measure of a person's intelligence or the ability to do a particular job. And it relates to the idea that those who land on top deserve their success. By these definitions, meritocracy is determined on the basis of skill, work ethic, success, and nothing further. And it asserts that there are really no other factors that have anything to do with it. And up until probably 3 or 4 years ago, if anybody had asked me about my story, I would have been very proud to say that I made it on my own. I came to Canada from the UK. I was an immigrant. I had the challenges of moving into a new culture. I took my first job at age 16 as a pizza delivery man, which is the worst job in the world, by the way. I earned money. I worked my way through school, and I've risen to a position of prestige and affluence. And I think that I did it on my own. But when you dive down quite deeply, it's actually not the case. And I recognize that I've had a number of blind spots and not acknowledging the privilege that I have as a result of being white, male, heterosexual. And this is something that I think now needs to be brought into the forefront, because meritocracy is really only true to its definition in an ideal world. And unfortunately, one of the urologists at one of the teaching hospitals in Toronto wrote this editorial based on the fact that when you analyze in urology meetings who makes up the constituents of the panel, it's mainly men. And he basically said that the reason that there's only men on these panels is because the women haven't earned that place to get and sit on those panels. And this was a game changer at the University of Toronto. This has now stimulated all sorts of discussion and analysis of this issue of meritocracy. And it really applies when you look at opportunities for women in surgery. And if you see as they go through their training and they move into leadership positions, there's definitely a difference in terms of the numbers of men that succeed to leadership positions and the numbers of women. This is because of attrition, lack of opportunity, and gender bias. And again, I thought that maybe at the University of Toronto we were a bit immune to this, but in actual fact, not. So if you look at the staff, we have 280 staff surgeons at U of T, of which 16% are female. And when you look at those females in leadership positions, like I suspect most places across North America, there's a huge discrepancy between the numbers of males and numbers of females. You look at the number of incoming residents, perhaps as an opportunity, only about a third of the incoming residents to the University of Toronto over a 10-year period were female. But what's interesting is if you look at the population and Canadian faculties of medicine by sex, in 68, 69, 14% were women. In 2015, 2016, more than half of these were women. So obviously there's something that's not quite coinciding here. We have women, but we're just not necessarily attracting them to surgical profession. And Alison Snyder-Warwick, who's a plastic surgeon at St. Louis, wrote this wonderful paper on women in leadership and their influence on gender diversity of academic plastic surgery programs. And what she's found is that while female residents have increased from 22% in 2007 to almost 40% in 2017, and the proportion of active board-certified female surgeons has increased from 12 to 16%, there are fewer women in leadership positions, and women represent only 9% of plastic surgery program directors and 5% of chiefs and chairs. And this was a picture I took last week at the American Association meeting in San Diego. And this is Alison sitting on the far right, and it sort of typifies this, I think, quite nicely. And so I think there's opportunities here to make things change. And again, when you look at staff diversity, there's huge issues in terms of indigenous, Black, and people of color, in that only 6.25% of plastic surgery faculty leadership positions were occupied by women who are them. And in Canadian medicine, we still have a significant diversity problem. This is the class valedictorian was the only Black woman in the medical student class in the class of 2022, even though there are almost 7% of community in Toronto that identify as Black. So I think there's some huge opportunities that we can take advantage of. And I came across two articles. This was one by a family doctor who talked about his privilege in a white coat. And he talks about his experience at shock trauma, where a young man came in with gunshot wounds who happened to be Black, who succumbed to his gunshot wounds. And when they were actually just cleaning up the body, they discovered he had 3 cell phones and 2 pagers. Somebody made a joke, well, he's obviously not a resident on call. He must be a drug dealer. And this happened, I think, 10 years prior. And this gentleman, Max Romano, continues to think about this, how racism shaped his image of this poor young man who'd been shot. And it was shared by the entire group in the trauma bay. And this is a wonderful article about how to become an anti-racist hand surgery educator. And there's great opportunities here to recognize implicit bias. This is a wonderful read that talks about the fact that we do have implicit biases when we see people of certain color or certain ethnic backgrounds. We make assumptions about those individuals that can impact in the way that they are treated. So what was interesting is about a month ago, we had a journal club at the University of Toronto. It was all by Zoom. It was on gender parity and gender equity. And we analyzed 3 articles. And unfortunately, one of our staff surgeons on the Zoom said, you know, it's really interesting because there's definitely a difference in terms of the opportunities for women in surgery, but ultimately it's a matter of earning the job. And, you know, I think that's a choice. That's a decision that you make. And if you want to invest in academic work and you happen to be a woman, then that's your choice. My choice is on a Saturday morning, I decided to take my kids to play hockey. I could work on papers, but that's my choice. And if a woman wants to have a family and be a surgeon, then obviously she has to make these decisions. And I have to tell you that sent echoes across the division. The residents started texting each other saying, WTF, what's this gentleman talking about? And it now created a series of debriefing discussions that we had. We had one last week. And we had a debriefing to talk about this issue of how women in our division are doing. And one of my colleagues called me up and said he felt very uncomfortable about this discussion. He said, when I look at the faculty in the division, I see all those women and they're all doing so well, and they're rising to leadership positions and doing really, really well. And he's missed the point, because that's not what the female faculty feel. They feel that they're struggling, they're having a hard time managing life, family, clinical productivity, academic productivity. And really, you know, equity really is a provision of opportunity, networks, and resources that support us to reach our full potential, but we don't work on an even playing field. And one of the analogies I think is you know, I play tennis, and if I was playing tennis with a 1968 Dunlop Maxply wooden racket with gut strings, I wouldn't stand a chance against anybody who's playing with a 2022 Babolat with graphite framework. So it's definitely an uneven playing field. And Sandra Landolt, who is the co-founder of the Canadian Women in Medicine Society, has said, once you see this, you cannot unsee it. I think that's very profound. And so I think the face of the academic surgeon is changing, and I think we need to be aware of that, and we need to embrace it. And I think designating surgeons into these pigeonhole categories is something that, while it works on one level, there may be some challenges in continuing to do this, and who knows what the future is going to bring for this. In my world, surgeon entrepreneurship is something that is just starting to take off. Karen and Dale Podolsky were co-workers with me in developing this cleft palate model, which is really Dale Podolsky's baby. And Karen Cross, who's the first surgeon entrepreneur in the division at the Department of Surgery, has really taken this to a very high level, developing all sorts of outpatient apps looking at wound healing. Global surgery is another area that I think we need to embrace, and gives an opportunity to spread our footprint across the world as academic surgeons. And I'll finish by talking a little bit about Simon Sinek. Simon Sinek is a wonderful author, and if ever you have never seen any of his TED Talks or read any of his books, I highly recommend them. Essentially, he talks about imagining a world in which the vast majority of people wake up every day feeling inspired, feeling safe wherever they are, ending the day fulfilled by the work they do, and he's part of that inspiration. And he wrote this book called The Infinite Game. And he talks about finite games like football or chess have known players, fixed rules, and a clear endpoint. The winners and losers are easily identified. In infinite games like business, politics, or surgery, or medicine, or life itself, The players can come and go, the rules are changeable, and there's no defined endpoint. There are no winners or losers in an infinite game. There's only ahead and behind. And he talks about the vast majority of leaders in business talk about being number one, being the best, beating competition. Trouble is, business is an infinite game, as so is medicine and surgery. The infinite-minded player understands that sometimes you have a better product and sometimes they do. There's no such thing as being the best, because in the infinite game, there's no such thing as winning business. The goal is to outlast and outdo yourself. And many of the struggles that organizations face exist simply because their leaders were playing with a finite mindset. And those leaders who embrace with an infinite mindset build stronger, more innovative, more inspiring organizations. I feel a bit embarrassed to be saying this at Stanford, but they did have the resilience to thrive in their ever-changing world while their competitors fall by the wayside. And I think this is something that I would recommend if you have an opportunity to pick up this book. He talks about all sorts of things like the just cause, trusting teams, a worthy rival, being able to flex and having the courage to lead. And it really is a very inspiring lead. So opportunities for the future. My feeling is that we need to change how we regard our academic surgeons. And certainly the opportunities that we use in applying metrics of papers and peer-reviewed grants are fundamentally important, but I think we need to change those. I think we need to reboot our evaluation system and rethink academic surgery and very much focus on mentorship and collaboration. And changing the face of academic surgery and changing that typical surgical personality is also something that I think we're moving into. So when I look at my own division, one of the reasons that I became an academic surgeon, I love in this quote, is because I love what I do. I really, truly love what I do. And I'm very, very fortunate to be able to work with young people, help them with their career, move the needle forward. And so my personal goals as an academic surgeon moving forward, enable the new generation, encourage diversity, help support our surgeon scientist trainees with career support, enable a state of art in clinical care, continue to support world leaders in innovation. And then for me, succession planning is something that's really important because my term as the chair and as leader is finished in June 2023. So I'm really hoping that I can influence the right people to be able to take over this. So Quo Vadis, this is an interesting thing. Where are we going? We could go anywhere. The world of academic surgery is very rich and very deep, and there's great opportunities for all of us. But I do think that these are areas that we start to need to pay attention to as we move forward. And I'll end by this quote. There was a paper that talked about surgeon scientists, a soon-to-be extinct species. And the author says a surgical investigator is a bridge tender, channeling knowledge from biologic science to the patient's bedside and back again. He traces his origin from both ends of the bridge. He is thus a bastard and is called this by everybody. Those at one end of the bridge say he's not a very good scientist, and those at the other end will say he doesn't spend enough time in the operating room. If only he is willing to live with the abuse, he can continue to do his job effectively. This was written by Francis Moore in 1958. So obviously the surgeon scientist continues to thrive and continues to be important in the world of academic surgery, but I put to you that there's other opportunities as well. And I use this quote often, Steve Jobs, we're here to put a dent in the universe. Why else would we be here? And I think future is highlighted here by one of my favorite musicians. Tomorrow belongs to those who can hear it coming. Once you lose that sense of wonder at being alive, you're pretty much on the way out. So I've been very fortunate to stand on the shoulders of giants with my former chairs at the University of Toronto. And really, it is a great privilege and honor to be here. And this is an area in Toronto. It's called Tommy Thompson Park. Any of you who come to Toronto, it's an area of reclaimed land by the water. And it was my COVID haven when everything was in lockdown. And I happened to be walking along one day and came across this quote, "Anything is possible," which I truly believe. So thank you, everybody, for the opportunity and for your patience and indulgence.